Like when do you think you will?
Try to finish fast. I have a few slides, but I'll try to finish like 8:20.
Okay.
At least 7. Yeah.
Okay. No worries. If you go like 8:31 or 8:32, I'm gonna stand up and. Good morning, everyone. Welcome to our grand rounds this morning. We have a special visiting professor from the Children's Hospital in Pittsburgh. Dr. Srinivasan Suresh is the director of the Division of Health Informatics in the Department of Pediatrics at the University of Pittsburgh School of Medicine. He's a professor of pediatrics and is also faculty in the Division of Emergency Medicine. I had to silence the second sound which is coming from my computer. Additionally, he serves as a chief chief information officer, chief medical information officer, and vice president at UPMC Children's Hospital, Pittsburgh. Dr. Suresh is a physician executive with a business degree and experience and achievements as a senior leader at 2 large children's hospitals in the areas of clinical care, information science, medical education, business development, and corporate strategy. As the CMIO at UPMC, Children's Hospital Pittsburgh, he leads a multidisciplinary teams in the application of advanced business intelligence to measurably improve healthcare for children. As a pediatric researcher, he's focused on implementing robust clinical decision support tools to improve quality, outcomes, and control costs. He's presented and published extensively in the fields of medical education, childhood emergencies, quality and patient safety, health information technology, machine learning, and predictive analytics. His scholarly work spans epidemiology, diagnostic techniques, therapeutic tools, clinical pathways, and value-based care. And he's also a practicing emergency medicine physician that I think got left off this. He's also a TEDx speaker and has been named by Becker's Hospital Review as one of the 50 hospital and health system CMIOs to know. In 2023, he was awarded the Healthcare Changemaker Award as a senior executive category by the Health Information and Management System Society. He serves as a chair of the Council of Clinical Information Technology of the American Academy of Pediatrics. He's also a member of the board of directors of the International Society for Pediatric Innovation, and he's a past chair of the Medical Informatics Special Interest Group of the Academic Pediatric Association and of the HIMSS Physician Committee. Dr. Suresh received his medical degree from the University of Madras, India, and then he completed pediatric residency and pediatric emergency medicine fellowship training at Children's Hospital of Michigan, Detroit, and then earned an MBA from the University of Michigan at Ann Arbor. So his topic this morning, and here's our CME code for everybody, and now let me get, okay, it's advancing. I'm going to hide the Zoom controls. And topic this morning is chat GPT and beyond, a pediatrician's guide to artificial intelligence. And for those of you who's, I first saw a very similar talk on that he did for the AAP webinar late last year, and it was just fascinating to me to see somebody who's actually practicing medicine using these AI tools in a way that we can relate to for direct patient care. So, Dr. Suresh, take it away.
Thanks much, John. Good morning, everyone. Thanks for the opportunity to be here and spend the rest of today as well as tomorrow meeting with a few other faculty, residents, and fellows. So the topic of this morning's discussion, ChatGPT and other large language models and beyond, a pediatrician's guide to artificial intelligence. I have no financial disclosures. Given the nature of the talk, I'll be using the names of certain companies, AI tools, and software. And clearly, these are just for examples and illustrative purposes, and I'm not endorsing any product. A quick outline, we'll spend a few minutes going over the background. What is AI? What is ML, DL? That's a little bit of alphabet soup. And AI in healthcare, and specifically in pediatrics, the past, present, and what I believe is the glorious future. There's a lot of hope and hype. A lot of you would have already seen that with the ChatGPT and LLMs. What are the specific applications in pediatrics and clinical care, education, research, patient experience, and advocacy, and a brief literature review. Objectives to one, to define generative artificial intelligence, and two, we'll spend a little bit of time to figure out how to create an effective and appropriate prompt for a Gen AI tool, such as ChatGPT, and identify a few aspects of our practice in pediatrics where we can use a generative AI tool to support high quality care or practice. So let's start with some lingo. What is artificial intelligence? There are lots of definitions. Sort of a working practical definition, and probably the shortest is what I like, which is replication of human intelligence in computers. Now, this deals with the theory and development of computer systems that perform tasks that normally require human intelligence, such as visual perception, decision-making, and speech recognition. Machine learning gives the computers the ability to learn without being explicitly programmed. So they're not clearly programmed or coded, so the machine learns using large data sets instead of hard-coded rules. Deep learning is a type of machine learning where we train a specific AI tool to predict outputs once a set of inputs are given.
Sorry, a couple of people in the chat said they can't see the slides, so we better
Okay, I'll pause.
better how do we get our voting meeting controls? Where did they go? Hopefully that will.
Thanks, John. For those of you who didn't see the slides, who didn't miss much. So we'll keep going. So deep learning is a type of machine learning where we train the AI to predict certain outputs when certain inputs are provided. Basically, this attempts to mimic the human brain where our deep thinking process happens. A neural network is a computer system model on the human brain and the nervous system. The impact of AI in pediatrics, a couple of examples. And thanks to Dr. Sharif Rahman, who's a neurologist and informatician at Chalk Children's in California, for sharing this slide, where he and his team work on an earlier diagnosis of autism. So how he does it is multiple sources here, which you can see on the slide, including videos of a child in his or her natural environment, playing, eating, etc., are collected to create a digital phenotype of the child. Using machine learning, maximally predictive features of autism versus neurotypical children versus children with other non-autism neurodevelopmental delays are identified. But in this slide, you can see that the healthcare professional completes a brief questionnaire about their patient's development and behavior. Just using a smartphone, the caregiver answers a few questions about their child and uploads 2 home videos, again, in the child's natural environment. All this data is fed through an AI-based algorithm. This results in a pretty highly predictive and accurate, positive, negative, or indeterminate result for autism. The tool also generates a detailed report guiding the pediatrician with the next steps. And this is the first diagnostic for autism authorized by the FDA. So you can see that, not only generative AI and ChatGPT, which we'll talk about, but there are other applications of AI which hold real world value for us pediatricians. So what is ChatGPT? The GPT stands for Generative Pre-trained Transformer. It is an example of a large language model. So what's a large language model? These are a class of machine learning models trained in autocomplete tasks. That's one of the ways LLM works. So what is autocomplete? So when you give the word coronary artery, these models may predict the next word to be either disease or bypass graft or calcification based on statistical parameters, which are learned from prior prompts. And these models have been growing increasingly larger, literally learning from billions, not millions, billions of parameters from many books, articles, and conversations all across the internet. AI is not new, but generative AI, or ChatGPT as we know of, is fairly new. And thanks to Joe Petro from Microsoft Health for this slide, and you can see the AI goes back to the 1950s. And in the 1990s, machine learning took off. Another 20 years later, deep learning. But just in the last 2 to 3 years, generative AI has taken off. In this slide, you can see three columns: companies, a fine-tuned chatbot, and the foundational model. So I'll just lay out the differences here. So OpenAI is the company that makes ChatGPT. So ChatGPT is a large language model. And the foundational model, GPT-4, is a paid version. It's $20 a month. Version 3.5 is free, and we'll get to both of those in a few minutes. And Microsoft is an investor in OpenAI. So their large language model, which is Bing, also uses the same foundational model, GPT-4. Google, on the other hand, uses a different chatbot. It was called Bard. Now it's called Gemini, and uses PaLM 2 as a foundational model. And I think PaLM stands for Pathways Language Model. And thanks to Dr. Hunter, who's an intensivist at Texas Children's, for this slide. So for those of you who have not used ChatGPT, it's really cool and fairly simple website. I think we try to mimic Google's sort of simple, background and platform for the prompts, and we'll do a few prompts in a few minutes. Talking about the medical AI chatbot. So there are two components. One is the chat interface, which you saw in the previous slide, which is a simple website, and a general purpose AI system in the background. And ChatGPT is widely available, and there are newer versions, 3.5, version 4, Turbo, which are in active development. How do you start a session? You start a session by entering a query. Till that point, it's fairly similar to a Google search, and that part is called a prompt. And the response by the natural language chatbot is typically in a few seconds, and it's fairly conversational, or you can make it fairly conversational. The system keeps track of the conversation, making it more natural and useful. And prompt engineering has developed into a field now because it really depends on how good we are in asking the questions and putting in the prompts. So this article gained a lot of traction early last year, looking at GPT-3 or 3.5. This was one of the earlier versions, innate medical knowledge, performance of ChatGPT on USMLE questions, and what is the potential for AI-assisted medical education. And just reading a sentence from the slide, ChatGPT performed at or near passing threshold for all three exams without any specialized training or reinforcement, when the question was just copy-pasted into the prompt box, and how accurate the answers were and what were the descriptions. So this is one example. I won't go through the full details, but for most of you, either it's prep questions or USMLE questions, you see the familiarity. It's a vignette or a case scenario. 12-year-old girl comes to the ED, 1 week history of swelling in her legs, etc. There's a description of the physical exam, a brief report of the urinalysis, and then the actual question: what is most likely to be abnormal in this patient? Is it bleeding time, or C3 or IgA concentration? So fairly similar question for USMLE boards or for pediatric boards. So posting that into ChatGPT, the correct answer came up as C, which is serum C3. And what I like is how the explanation comes up. So this patient has signs and symptoms of what the actual disease is. So this part was not underlined. The underlining was by me, but now you can prompt it to underline the keywords. So it tells you the answer was, the condition was post-streptococcal nephritis, and serum C3 level is low. And then in 1 or 2 sentences, you get an explanation as to why A, B, D, and E were the wrong answers. So what we did, and thanks to my colleague, Dr. Sangamitra Mishra from Texas Children's, this is unpublished data. So we used the 2018 version of PrEP. The previous question you saw was for the USMLE board. So this is for PrEP, which all of us do, and I went with 2018 because that was the free version available online, which had 277 questions. And at that time, when we did this exercise in October, we looked at 34 questions that had some kind of image in them, either a rash or an X-ray or a CT scan, growth charts, peripheral clear. So we excluded those, and the remaining 243 questions were inputted into GPT-4 as a prompt. No formatting required, just copy-pasted. And the accuracy, the correct answers was 78.2%, which is pretty good. That's definitely above the board passing score. And the explanations were generally shorter, and some of the keywords were bolded. But I also feel this is an unfair comparison, because when we get, the PrEP book or the software, you also have an answer key with explanation. You have the PrEP calls, ABP content specifications with every question, and some suggested readings. But I'll give an example of why this still has some value. So this is one of the questions which was from the PrEP series and inputted. And you can read the question from the slide. a 15-year-old boy offers for a sports pre-participation evaluation and is asking for some kind of injury without going into the details. So this is what you have it in prep. It's a little bit hard to read for a learner like me, where it's a lot of text and no, keywords are bolded, no images, etc. And putting it into ChatGPT, it was a little bit different. It gives the answer. The answer was A, basketball has one of the highest rates of dental injuries among high school sports. It gives an explanation. And I said before, it gives you why the other options are incorrect in a shorter sentence. So my prompt to GPT was, can you please, I try to use the word please to make it more conversational, can you please shorten the explanations a little and also bold the keywords? And it does that. So I'll pause for a second. If you think about it, for a lot of us who are primarily visual learners, just looking at paragraphs and paragraphs of text with no images and no, color in them or no highlighted words or keywords, it's going to be hard. So this is, I think, where there's value with this. Shifting gears, my question to ChatGPT was, can you please explain how to use albuterol MDI with spacer for asthma as a rescue inhaler to a 10-year-old child in 5 steps or less? The reason why I'm asking 5 steps or less, the first time I did it, it gave me 9 steps. Nothing wrong with it, but you can adjust your prompt to specify, can you do it in 5 steps, 3 steps, 7 steps, pick your number. When it does that, of course, let's make this simple and easy to understand for a 10-year-old, and you can change this to a 5-year-old, for a college student, however you want to. And the first few words of every sentence is bolded, so which is nice. And I said, thank you. Can you please adjust this above education for a 5-year-old child with asthma and still do it in 5 steps or less? It actually gave me 2 responses. I only have put response 1 here. You can pick either. And I'll pause for a second while you read that. And you can see these are words which most 5-year-olds will be able to comprehend. Although I probably wouldn't know what a puff bottle means. So I'll skip that. Thanks much. Can you please now adjust the above education, provide instructions for a parent of a child with asthma and still limit to 5 points. So you can see where I'm going. It's the same content at a higher level, but it's for a 10-year-old versus a 5-year-old versus the parent. So when it does that, and this is at the adult literacy level, the next one is, can you please translate this above piece into Spanish to be read by the parent? And it does it in a few seconds. I do not understand Spanish, but I ran this by Dr. Mishra, who is a certified translator, and she felt that this was pretty accurate. And the last time I checked, this was a few months ago, ChatGPT has the ability to translate into 26 languages. I think the number is higher now. So that's also very useful. Switching gears again, so taking a journal article, and some of you in emergency medicine would have read this, and a shout out to Tessie Neville, who's the second author there. She's one of my colleagues in emergency medicine back in Pittsburgh. And this is about the validation of septic knee monoarthritis prediction rule in a Lyme disease endemic area. Pretty standard article in peds emergency care. And this is copied from the abstract. You have an objective, methods, results, and conclusions. It is still a little hard for me to read, or at least to retain what is in this abstract, because it's a lot of text, it's a lot of numbers in the results, so it's going to be hard for me to do a takeaway. So I copied this, just the abstract, not the full manuscript, into GPT, and my prompt, which is important, is please assume the persona, and you hear this word, you can ask these LLMs to assume different personas of a physician, of a medical student, of a social worker, of a radiologist. You can take your pick and provide conclusions for the study in 5 bulleted points. And it does that. And this is just from the abstract. You can see what the differential presentation is, the prediction rule, the study population, which is laid out in bullet points, the effectiveness of the prediction rule, and how is it useful as a diagnostic intervention in low-risk children. So just comparing this to the actual abstract, you could see the difference in sort of the retaining power of what you can learn from this. And you could do this for the full manuscript too. I just happened to pick the abstract for this. What else can these large language models do? They can produce notes in various formats, including a SOAP note. They can include appropriate billing codes automatically. And beyond the note, they can be prompted to answer questions about the encounter, extract prior authorization information, generate lab and medication orders, right after visit summaries, especially if you have a child with, multiple visits to the hospital, multiple ER visits, complex issues, and provide critical feedback to the clinician and patient. How valuable or accurate is it for actual clinical care? So the jury is still out. I wouldn't place that as the first use case scenario, but I'll mention this case. This is from Professor Renato Sabatini's blog, and he is a physiologist and an informatician. So he talks about a 3-year-old healthy female started to regress in language and motor development, developed seizures, have had abnormal EEG. The parents went to a lot of doctors, had differential diagnosis, epilepsy, a bunch of syndromes. The treatments also varied. She was on 8 different medications, no improvement. So still there was not a clear diagnosis. After 4 years, exome sequencing was done, and the diagnosis was obtained, which happened to be an atypical variant of Rett syndrome. It is incurable, but has a relatively benign evolution, survival, and symptoms. She received multidisciplinary care, good ending. She's doing very well, good recovery of many of the lost functions. So all good. So how about if you summarize this case, which happened over a few years, into ChatGPT? So female patient, 4 years old, normal at birth, presented with the following manifestations from the previous slide. To summarize a little bit, and ChatGPT's output was based on the symptoms, patient in question may be showing signs of Rett syndrome. So that's pretty impressive. This doesn't happen all the time. So for all the rare diseases we see, for all the zebras we see, I'm not implying that you can put in HPI and physical exam and it spits out the differential diagnosis, not at all, but it's a good start. So in cases where we get stumped, at least we can start with it. And for teaching purposes and training purposes, it's a good start. So it does that, and then it gives a lot of disclaimers. These symptoms can also be caused by other disorders and conditions, and it gives other possible diagnostic hypotheses. So for a non-geneticist or a non-neurologist, this is very good. All right, what else can ChatGPT do? Appointment scheduling, patient inquiries and FAQs, billing and insurance inquiries, referral coordination, internal knowledge base. And I'm going to read this sentence. It's important. It's important to note that while ChatGPT can automate certain back office functions, human oversight and verification are still necessary. Additionally, data privacy and security should be carefully considered when integrating GPT into medical back office systems to ensure compliance with relevant regulations. Any idea who gave this quote? It was from ChatGPT. So it's a lot of disclaimers, legal language, but it's good defensive tactic, I guess. All right, quick literature review. How many of you have seen this article? It's from different authors. It was Chris Longhurst, who's a pediatric hospitalist, I think, from UC San Diego and others. So this gained a lot of traction comparing physician and AI chatbot responses to patient questions posted on a public social media forum. I think it was Reddit. So the hypothesis was AI assistants could potentially aid in creating answers to patient questions by creating responses that could be reviewed by clinicians. So you can see the objective, and this was in November 2022. So things have gotten a lot more accurate and technical and useful since then. So the design was 195 questions drawn from a public social media forum where a verified physician had responded. The original question was entered into a chatbot session, and the anonymized responses were evaluated by licensed healthcare professionals. I think there were a couple of family physicians, a couple of pediatricians, internists, etc. The evaluators chose which response was better, the chatbot versus human, and judged quality and empathy on a 1 to 5 Likert scale. The evaluators, who were physicians, preferred chatbot responses to physician responses in almost 4/5 of the exchanges. The physician responses were significantly shorter, doesn't mean inaccurate, but just they're shorter than the chatbot responses. And generally speaking, the chatbot responses were rated as higher quality and significantly more empathetic. So you can see the conclusions on the slide. Chatbots can draft the responses, which we can then edit. But more trials are needed to really say, is a chatbot more empathetic than the prototypical physician? This is the quality ratings, that's the empathy ratings. There's a lot of overlap, as you can see, but generally speaking, you can see the scoring, the density of the chatbot response exceeded the human responses, both on the quality and the empathy side. And just picking one question here, so you get an idea how the responses were. This is about the risk of dying following swallowing and ingesting a toothpick. The physician responds to the point, very direct. If you have surpassed 2 to 6 hours, then you're good. For now, they won't be doing much, right? To the point. Chatbot's response, it's natural to be concerned, toothpicks are made of wood. If you're experiencing any discomfort, it's always a good idea to be cautious. So you can see that from a patient's or a parent's perspective, just comparing these two paragraphs, you can see at least the perception of empathy, if not the real empathy difference here. So, and of course, you can also fine-tune this chatbot response to be longer or shorter at a 10-year-old literacy level. You get the point. Switching gears a little bit, what are we doing at UPMC Children's where I work as far as AI-driven tools? So we use this tool called a Bridge, which is a tool for ambient listening and documentation. So this is the workflow. So I use it in the emergency department, especially when I'm seeing patients on my own without trainees. So the recording, the conversation is recorded. I explained to the parent that I'll be recording this so that my note will be quicker. There is no additional consent needed. The complete conversation is recorded, and it takes about 60 seconds. By the time I come back to my computer from the patient's room, I get 3 outputs. One is the complete audio recording. Let's say I spend 6 minutes in the room. So that is there. And then a text rendering of the complete recording, word for word. And then the actual note, which is in the format of HPI, review of systems, physical exam, medical decision making. So it is very good. It removes all the icebreakers. If I talk about the weather or the Pittsburgh Steelers game, it removes all those and just focuses on the discussion. So that's a digital record which can be copy pasted into your EMR. So we are running a pilot. We've had more than 1,000 users so far in various clinics. We've not used it in our inpatient side yet. So it's in clinics and in the ED. We have 60 unique clinicians using it, including myself. 20 of us have used it, 20 providers have used it more than 10 times. One of our pediatric nephrologists has used it more than 100 times. He sees a lot of complex patients. His interactions are sitting with a family, talking for 15 to 20 minutes, which is very different from me in the ED, seeing a patient for 5 or 6 minutes when another sibling is running around the room. One of our pediatric surgeons really loves it, and she used it over 100 times. The average experience rating is very good, and these are the strengths. It generates a near complete note. I'll say near complete. The first couple of times I used it, I had to make 2 or 3 minor edits. The last time I used it about a week ago, I did not have to make a single edit. So it was perfect. I copied the HPI, physical exam, MDM, etc. So it definitely saves time. It provides a complete audio and text transcript. It does have a few limitations. It does not list all the lab and imaging data during the encounter, and you can argue it doesn't need to go into the note, word for word, but it summarizes them. If I had said blood sugar of 40, it may, record a hypoglycemia, etc. And the assessment and plan is relatively brief and does not include all points from the medical decision making. I still feel that the limitations are minor. It doesn't affect my E&M coding for that patient. So how does it do all that? I'll give you quite a few examples. There is a lot of technology that goes behind ChatGPT and LLMs. And if you talk to the experts, they'll be able to explain it to you, but almost every expert will say they still don't know exactly how it does it because it's not explicitly programmed or coded, right? It learns from itself. So I'm going to talk about some of the technology behind it. One is called part of speech tagging. So when we say the book is on the table, book is a noun. When we say she'll book a flight, it recognizes that book is a verb. There's this concept called tokenization or word segmentation. And when we say the dose of amoxicillin is that much, amoxicillin is a token, the actual dose is a different token. And if in our note it says Dr. Smith is meeting Dr. Khan in the library, it figures out Smith and Khan are persons and library is a place. And also stemming, which is important. So the words infarction or infarcted or infarcting are all grouped under infarct. At our place at UPMC, we have an ongoing collaboration with the technology infrastructure team. And what we're doing is we're looking at our notes. And this is sort of partial list. And we take sentences in our notes, progress note, operative note, etc., and put them into these categories: anatomy, demographics, examination. And I'll give an example. So this is a line which says he does have itching and rash on his neck and arms. So itching, UMLS stands for Unified Medical Language System. So it's a coding system. So that goes under symptom or sign. The rash is symptom or sign. Neck is a body structure. Arms a body structure. His back pain improved the next day. You can get the concept. It's either a symptom or a sign, course, or time. It doesn't have to be a full sentence. It could be a structured data in your EMR in a cell. Hemoglobin greater than 9.5 grams per DL. Hemoglobin is the exam name. And you have a relational operator less than or greater than or equal to value and the unit. And another example on the screen there. In the last one, she was continued on antibiotics and was afrobel until day number 5. So day number 5 is the time. So you can see the various buckets or the domains to which these sentences are categorized into. So that is one of the technology that's behind these tools. So what's happening at the national level? So it showed you a lot of examples. We'll talk about the legal aspects and ethics and governance for the next few minutes. So AAP's Council on Clinical Information Technology, and I'm fortunate to head the exec committee for that group. We're working on expediting, creating a policy statement, and we're having ongoing meetings with AAP exec leadership on what the academy can do and should do to address the harm and benefits to children from these new technologies. So we showed a lot of examples for clinicians, but do these tools harm children? So it's different from social media, it's different from video games, it's a completely new category. So we need to look at harm and ratings, and that's what the AAP is also interested in. At the federal level, this was in July 2023. It started off, the administration secured voluntary commitments from 7 companies, from what I recollect, Microsoft, Google, Meta, etc., to manage the risks posed by AI. And a few months ago, President Biden issued an exec order on the safe, secure, and trustworthy artificial intelligence, which is basically a framework. And very recently, this was just 5 days ago, Health and Human Services AI task force takes shape. So you can see these things are happening at the federal level, probably at your state level too. But it's important for us at the organizational level, what are the policies for Phoenix Children's Hospital, Children's Hospital of Pittsburgh, for us to use or not use with our patients. How does the public take all this? And this was more than a year ago. Please keep in mind, I feel the sentiment may have changed over the last year. And 60%, and this was a survey which went to over 1,000 adults. As you can see, the top's not coming up. 60% of them were uncomfortable if the healthcare provider relied on it for medical care. Now, these kind of questions are also tricky. We do use UpToDate and Google Images and so many things in our daily practice. How much of that is technology and AI, it's hard to say. So, but you could see that the majority were still uncomfortable. And 38% felt that it would lead to better health outcomes. Almost the same felt that it could lead to worse outcomes. Among those who see a problem with bias based on race or ethnicity, 51% think relying more on AI would make the issue better. And 33% felt it stays about the same. You may have heard the word hallucinations. So that's the term for mistakes, what these large language models make. So this is from mid-2023. The question was posed, fairly simple. What is 3 times 4 plus 9 times 9, right? And this is quite a few months ago. Give the answer first and then the explanation. Lots of problems here. It says the answer is 99, which is inaccurate. And it goes through an explanation, which is pretty accurate. And then it gives the correct answer, 12 plus 81 equals 93, which is fine. Therefore, 34 plus 99 equals 93, which is not correct. So you can see how unreliable this was a few months ago. And the exact same question, I tried it 2 days ago. Give the answer first and then the explanation. The answer is 93, which is accurate. The explanation, you have to do the multiplication first and all that. Fairly simple math, and it gives you. So I'm putting up this example to show that there are a lot of smart people in technology. I've had the good fortune to talk to a couple of them who are very cognizant of the hallucinations, especially what we would see in healthcare, and are working to mitigate them. Legal ramifications, security, what I'm going to show, and the screenshots are all from a public version. But once you have it in your hospital system or university system, that's a licensed application. So the security and privacy issues are very different. And we should not be entering any PHI in the public version. Let's not assume that the data, patient data we enter, especially a patient's name or address or social information, etc., will not be taken into consideration. So we should never be entering any PHI. Very little case law exists. So there are a lot of unanswered questions as to the governance. How do current malpractice laws apply to AI-assisted medical decisions? I don't have answers to these questions. We're just putting it up because there's a lot of discussion going on. In case of misdiagnosis or treatment failure involving AI, not just generative AI, but other AI tools, who's responsible? And what are the current regulatory standards for pediatric healthcare, and are they sufficient? Thanks to Dr. Robert Turbo, who's a neonatologist and a lawyer, who works for Dignity Health. And he posed these questions, so which is again food for thought for all of you. Does my hospital or your hospital have recommendations for specific use of AI? Does your EHR have an integrated AI program, which is always important, right? It's nice to have this tool, but you don't want to open up a browser, log in, and should be completely integrated into whatever EHR we're using. Did the pediatrician evaluate available information and the AI input? Was the AI a substitute for patient care? And it's really going to be difficult to demonstrate that the AI company, OpenAI or Google, has a duty to the patient. They have a duty to make the software better, but when we're using it in healthcare, it's very difficult to argue if an error is made that it is the software company's error. All right, I'm going to quickly go to demo. We're good with time, John, right? Yeah. Right. So I have, this is my version of ChatGPT. It says GPT-4, which is a paid version, but I could go to GPT 3.5, which is the free version. So I've logged in here. And what I'm doing is two examples. One is, this is an actual imaging report of a patient that I saw. There's no PHI. And these are the findings that you can see. I've underlined some complex words here, complex from a patient's perspective, apex and volar angulation, no dislocation. So I'm literally copying and putting it in here, no formatting needed. And I can say, please convert into simple English. You can see the difference, and then I can say, can you please highlight or bold the keywords? You can actually prompt it to not use the word radius and ulna, and it's very cool. It actually says, when you keep your hand prone, the bone that goes from the elbow to the thumb. So it actually says that to replace the word radius. And keep in mind that even if I made one or two minor changes to my prompt, the answer may be a little bit different. And just to inject some humor, can we say, can you please convert this to Shakespearean English? Let's try that. The patient doth possess fresh fractures. These fractures are angled, which is fine. There's also swelling, no other fractures, and there are no bones dislocated. Again, this is very different than what I got yesterday because my prompt may have changed by one word, but it actually said no other bones were astray. I can't think of any radiologist who would use those words. So just to inject some fun. The next one I'm going to do is when I click on this, it opens up a few other plugins or add-ins, as it's called. So there's one called Data Analyst, and you can create flowcharts, videos, PowerPoints. So you can do lots of those things, and I'll demonstrate some of those in the sessions with the fellows. But what I'm going to do is quickly put in a file here. So this is a very simple Excel file, just 3 columns, made up numbers. It says, these are the months, these are the deaths in hospital A and deaths in hospital B, right? So I'm going to copy paste this into ChatGPT and ask for some inferences. I can either highlight and copy paste, or I can just drag and drop the file. So which is what I'm going to do. So I click on this and it goes to the folder in your computer. So this is the file. I'm putting it in. Oh, sorry, I should have gone to Data Analyst. Okay, let me do that one more time. And I can say, please analyze and interpret the data. Takes a few seconds to analyze, depends on your connectivity speed. It already calculated a standard deviation for both of those columns. And if you put in more data, you can ask for sensitivity and specificity and predictive values and likelihood ratios and accuracy and all that. So that's the summary. The nice part is it says, would you like to proceed with that or focus on some other aspect? And when you click here, for those of you who actually want to know the code, you can pick up the code, you can copy the code and share it with other researchers, etc. So I'm going to ask, so based on this, it looks like hospital B had a lot more deaths. Is that right? Okay. So does this mean hospital B is not as good as hospital A? This is very useful. And a lot of us can make that judgment. But if you think about it, when we are teaching, students and nursing students, it's good to say that, okay, these are the 4 reasons where we should not come to a conclusion just based on the data that hospital A was better than hospital B, right? So this is where I think it excels. All right, going back to, I just made screenshots. I was worried about the connectivity, but it worked. Okay, so what generative AI is not? It is not sentient. It does not have feelings or understanding. The responses you saw, they mimic, in most cases, human-like responses, but no emotions or ability to feel. It's a very sophisticated and complex statistical model, but you won't find any intuition or moral reasoning or true understanding. The data is not perfect, nor is the analysis, but as I showed in some examples, it's certainly improving. This is an important slide. You may have heard of biases, and thanks to, again, Dr. Lund for sharing this. And I tried this again 2 days ago, and it sort of gave me the same answer, which means it has not gotten better with recognizing biases. So the prompt was, please draw a line diagram of a doctor. That's what it came up, okay? With the white coat and stethoscope and all that. Please draw a cartoon of a doctor. A cartoon of a pediatrician. Fair enough, but you already see some biases there. Okay, when we have majority of the pediatricians either in training or in practice are females, you get a male image there. Please draw a cartoon of a Black pediatrician taking care of a white 3-year-old. So first attempt, error. Okay, this is real. Second attempt, this is what I got. So it's really hard it's a stretch to say that that's a Black pediatrician taking care of a white 3-year-old. So beware of the bias in responses. It still exists. The technologies are very much aware of this, and it's still there. Okay, some quick publication tool or reference tools. AI in medicine is a series in the New England Journal of Medicine. These are not very long articles. I love them. Strongly suggestion to read. There's also a new journal from the NEJM. And just to give an idea of the editorials, what they look at, the trials must be pre-registered, policy in progress. There's also a Grand Rounds podcast from NEJM. And I follow a few people on Twitter or X for their feeds. Some textbooks, Intelligence-Based Medicine by Anthony Chang, Stephen Wolfram's What is ChatGPT Doing? And 2 very easy read books by Harvey Castro, who's an emergency physician, on ChatGPT in healthcare, and Bing Copilot. What are we doing from the AAP? There is an AAP AI in Pediatrics webinar series, which John alluded to. It's almost every month now. We've had 6 sessions so far, open to any trainees, AAP members. All 5 of those are on the website. Actually, as of this morning, all 6 are on the website. So that's a screenshot. And this is on the public web. So it's not just even for AAP non-members, but it is for anybody in the public. We made the decision to post these on the public web. There could be local resources too. Not exactly familiar with what you have in University of Arizona, but at the University of Pittsburgh, we have a website which is fairly detailed under the University Center for Teaching and Learning, ChatGPT resources for faculty. And these are the questions faculty will have, or even residents and students will have. So we give some very prescriptive answers to such questions. This was a seminal paper from 15 years ago, and I'll mention why I'm bringing this up. A fundamental theorem of biomedical informatics. This was by Professor Friedman. In figure 1, you can see the fundamental theorem of informatics, and in figure 2, what informatics is not. So in simplistic terms, he talks about how information technology can augment human reasoning. And the plus sign here is not to be read literally, but just to convey the interaction between the person and the resource. Okay, some of the bad things that are happening. So such kind of studies, to me, are clickbait. These do not help. This was 7 years ago, but when it says Stanford algorithm can diagnose pneumonia better than radiologists, and another clickbait was AI versus doctors, these articles really don't help the cause. And this was also a flawed study. The AI tool looked at a single view, AP or PA view of the chest X-ray, where no clinical history was provided. And all of us know that's not how a radiologist or we read our images. And one other point I want to make on the slide, I think we, healthcare community, pediatricians, we have an obligation to partner with the smart technology folks and drive this change and not just be a follower. Because otherwise I feel what happened with billing and coding 30 years ago and with the wide adoption of the EHRs 20 years ago, that we were passive. We as in clinicians, physicians are passive, and we did not take the lead, and we were left behind. And that has led to significant frustration from the majority of clinicians, despite what we feel we've had a lot of successes from health information technology. Last few slides, disappointments, lot. This is from Anthony Chang, who's a leader in this field and an evangelist. He's a pediatric cardiologist from Chuck Children's. And he says there's been a lack of early collaboration between data scientists and clinicians. That's important. And we always, at least I tell my data scientists and the technology folks, please come to me with problems. Please don't come to me with solutions. Let's work together. There is still a publication to practice schism, poor performance of AI-enabled decision support. The ethics are still underemphasized. There are very few business models for AI services, and very few of these are integrated into our EHRs. All right, that was a little pessimistic, but there are lots of good things going on. How many of you have heard of Khan Labs, Salman Khan, Sal Khan, or Kamingo? This is really cool. This is not directly related to pediatrics, but definitely to children. So it's a chatbot similar to ChatGPT, but they have their own API. It works like a real life or an online tutor looking at students' work and helping them when they get stuck, especially with complex math problems. And it can detect not just whether a student got an answer right or wrong, but also where they may have missed in the reasoning. So here's a screenshot. Of course, the child is going to ask, can you just tell me the answer? It is important you learn how to do this. What do you think you need to do to multiply 2 by 5/12? The answer is they need the same denominator. That's a good thought. But in this case, you don't need to find a common denominator because you're multiplying, not adding or subtracting. And you can fine tune it to highlight those keywords, multiplying, not adding or subtracting, so you don't have to prompt it again. So you can do all sorts of things. So that's more at the local level. So just thinking outside the box, projecting into the future, can generative AI address, global health issues that what we see for kids? As example, combating food insecurity, it can. There are specific tools. The World Food Program has a tool called Hunger Map Live, which optimizes supply chain operations and delivers food assistance to more efficiently those in need. A similar one called Harvest Plus, and another one called Aware or Aware, where the company uses AI and machine learning to help farmers make better decisions about planting and harvesting. This does not solve the last mile issue, as we call it, to how do the children actually get the food, but none of these technology was available as recently as 5 or 10 years ago. So concluding, AI and related technologies are here to stay. The machines do not have the downsides of human nature that clinicians face. I'm not confident that I'm as complete or accurate or empathetic in my 8th hour of my emergency medicine shift as I'm in my first hour, right? So the machines don't have that issue. Collaboration between clinicians, amongst clinicians and between clinicians and technologists, and the adoption of AI is certainly needed. And this is a quote from Bill Gates: we always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. I still feel the best medical technology of all time is the stethoscope. I do use my smartphone at the bedside, and I can give a couple of other examples. The Abridge AI tool that I showed, which helps me, record a conversation and take a note. So I use my smartphone. I do not use a computer or a tablet. I don't take a computer on wheels next to the patient's exam room. I never intend to do it because I do feel that there is a barrier. So it's really a matter of, how do you use all this technology and still be empathetic and take care of the patient and not have the computer monitor or other technologies in their face. And I'm not worried about my physician job. I don't feel I'll be replaced by a machine or by a robot or by a computer. But I may be replaced by a physician who understands machines and robots and computers better than I do. All right, rounding up with the two really quotes that I like. This one is from Peter Drucker, who was a management consultant, educator, and author. If you cannot measure it, you cannot manage it. And someone, I don't know who, went one step more and said, if you cannot automate the measurement of it, it's really difficult to improve it. And the last quote by Professor Deming, was a management consultant, engineer, and statistician. In God we trust. Everyone else must bring data. There he is. And thanks for listening.
Okay, we've got 8 minutes for questions. There may be some residents out here, but you've got 6 good ones in the Q&A. So why don't you, the Zoom audience always complains that they don't get to hear the questions.
Oh, can I just click on the Q&A here?
That way you can read it.
Sure. When LLMs generate false information, the term hallucinations was coined. I'm curious about the origin of this term. Happen to know? Sorry, I do not know. I do think that that's a cool term, though. Delusions would have been worse. I would go with hallucinations. My understanding is that the LLMs are dependent on looking backwards at databases. Is there an LLM that can look at data in real time to generate answers? This is a great question. In general, LLMs are dependent on looking backwards. And earlier versions, GPT-3, 3.5, I think they stopped. The database stopped at somewhere in 2021. The newer ones are more up to date, but not up to date as of yesterday. Having said that, there is at least one. It's an oncology LLM, so it is built from the ground up, which looks at real-time data within their hospital's EHR or clinical trials or the pediatric oncology groups or the clinical oncology groups data. So that's coming up in oncology. It's a great question for another reason. I think that's where healthcare LLMs should go. Imagine in a couple of years if we have a pediatrics LLM built from the ground up, which will have all the past data and pretty much all the evidence that's being published in pediatrics, all our clinical trials, etc. So, does PCH currently have any AI tools that staff can use, i.e., that are secure? I defer to you, John and Vasu, and other faculty here. We can certainly discuss more. I wouldn't know.
Not generative AI.
Not generative AI.
But nothing generative right now.
Okay, so that's the answer. Nothing generative, but still some exist. Not to be used for PHI. Okay. Yeah, and this is also interesting. We have at Pittsburgh, I'll sort of flip the question. At my place, we have 2 that I know of. One is Abridge AI, which is the ambient listening tool, which is generative AI. And we also have another tool in emergency department, which I can share later, which is used for patient engagement, which sends out a text message. It's not an app, text message to the parent and the family when they come to the ED and sort of tells them about the progress through the ED course. And it is based on time of day, how busy it is, etc. So there is some AI built in there, which is not generative AI. Question about the format of data accepted. Are there any AI formats that read data from the PDF file that is generated, or is raw data always needed? So the answer to that question is this has gotten really good. If I had time, and maybe one of the other sessions I'll show, you can literally take an article, most articles, drop it in using the file, add file link, and the article is a PDF, and you can ask GPT to generate 5 or 10 or 20 PowerPoint slides. It almost sounds too easy. So if you're doing a presentation, you can have that. And it's a start. I'm not implying that, that should what residents should use for the presentation tomorrow, but you can, it's a good start. So the answer is both. It can read from various types of files, PDFs, Word documents, Excel files, etc., as well as raw data. How would a health insurance plans use AI for prior authorization decisions? This is tricky because it's going back and forth. The clinicians can draft letters to make the case for payment, and the health insurance companies can also do that. Although there are some, maybe not laws, but some standards coming up that insurers and payers cannot or should not be using AI for denials. I don't know if they are different by state. Do they need the raw data from the provider's EHR to perform this? It's a great question. I don't know the answer as to how much data, raw data the insurers have regarding a particular patient or an encounter. How does AI generate a PE within the note, dictating the PE out when the room? Does this lead to additional questions? Another great question. I've also changed. I'm almost talking to the average AI while I'm doing this, which I didn't used to do a lot. So when I was examining this particular patient, I was talking with the parent and almost summarizing what the parent was telling me. Also, this has been going on for 3 days. So you're saying he did not have vomiting. When I was examining the child, I almost went through the HENT and the rest of the system. His right ear looks fine. His left ear does not look fine. So I was sort of talking to the parent, not to the software, which was very conversational, but it does help making my note better. So if I do that, I'm spending less time on editing the note. Have you used AI to take meeting minutes? I have not used it, but I've noticed people doing it. And in Zoom, I saw this function just a few days ago where there is a AI summary or something like that. And there are a few other tools, and I'm not mentioning the product names, which can do a great job of this. Even in virtual meetings, not just taking notes, but it parses out what the action items are. And if 3 of us, I'm just picking on John and Vasu here, we're on a call and we left saying John's going to do this, Vasu's going to do this, it sort of puts it out and say, okay, these are the things for the 3 of us to do. So it is very good in taking advanced notes, I would say. And when it's getting integrated into our online meeting tools, such as Teams and Zoom, that carries a lot of value.
One from the floor and no.
Thanks for the stuff. It's great. Speaking, you talked about kind of the rapid expansion of these models and speaking on kind of bias and discrimination in this, and how, for example, OpenAI is owned or operated by a single person. How do we ensure these models, like the data they get or the data they collect, are from, like the sources we would trust, for example, and not, like how do you treat sickle cell disease, for example, to make sure that it's not like from Elon Musk's like email inbox or something like that. To ensure that, like, we're using these models to train like trainees and learners, that we're giving them like accurate, more up-to-date information versus like the musings of some crazy person.
Yeah, it's a great question. It's not going to be easy, but if you think about it, you could Google search what you said in treatment for sickle cell, and you would get a lot of inaccurate information. Hopefully not on page 1 of a Google search, and they're hidden in page 17. So there are easy answers for it. So I think especially in healthcare, I think we need to make the case that this is evidence-based medicine, and these are publications, and these are clinical trials, and this is what was presented at national conferences, and those should come to the forefront of the extraction. At least in Google search, the way the results come up, you have the link, right? It goes to cdc.gov or it goes to the page. With GPT, that's another issue. You get a big blob and you can color it and highlight it. You have all those pluses, but there is no link to where that data came from. So great point. It's not an easy answer at all. And I think we can just keep striving. The governance for healthcare AI, I believe, should be a lot more stringent than what it is for other modes. Yes, please.
I was gonna ask, have you heard of open evidence? Just in like the mail-based AI, I don't know if other institutions have something similar, but I know I have used that and it gives me like the literature and sites like directly to like PubMed, so I can get the sources of what I'm asking. So I don't know if I don't know if that was kind of less important question. I don't know if you've heard of more AI models that are similar to that other institutions might be developing that are more catered toward like medical information and analytics and evidence based.
Yeah, great point. I have used open evidence. I didn't put a screenshot. And you're right, you can ask very similar question what we use ChatGPT for. And in the output, which is fairly similar, you get direct reference to high quality literature. It picks up, okay, this was published in NEJM or Nature, or so it puts those up. And there's also Claude, I think CLAUDE by Anthropic, which is trying to do it the same way. It goes back to the early years of search engines, right? You had Google and Alta Vista and so many others, but now Google's leading it. Does it give always perfect answers? I don't know. So some of these may be more tuned towards medical searches, but the jury's still out.
To that point, you can ask ChatGPT to provide sources, but just also be aware that that's one of the ways that it can manifest the hallucination. Like it can give you like very back-looking citations, but then you put that in PubMed, it may be a hallucination.
Yeah.
There's actually a study published about like citation hallucinations.
Yeah, absolutely. Yeah, that's an issue.
I think we need to end it. Everybody's welcome to come up and put the speaker.
Thank you.